We appreciate the opportunity to present our paper, OpiTrack, a wearable-based clinical opioid use tracker with temporal convolutional attention networks. This work was a collaborative effort between UMass Amherst, Department of Computer Science, and the UMass Medical School, Division of Medical Toxicology. My name is Bhanu Teja Gullapalli, PhD student at UMass Amherst. Today, Dr. Stephanie Carreiro and I will jointly present our work.
Opioids are a class of drug that bind to receptors in the brain and nervous system. In addition to providing effective pain relief, they have a number of other physiologic effects, including euphoria and sedation. Opioid use can have many detrimental effects in the short and long term, including tolerance and dependence. Tolerance occurs when increasing dosing is required to achieve the same effect, and dependence causes distressing withdrawal symptoms once the drug is discontinued. Both of these can contribute to the development of opioid use disorder, also known as opioid addiction. Physicians need opioids to treat pain, but careful monitoring is necessary to prevent misuse and addiction. The current state-of-the-art methods for monitoring opioid use are self-report and biologic sample testing. Self-report suffers from inaccuracies due to recall bias and intentional concealment of opioid use. Biologic sample testing, such as urine, blood, or hair testing, suffer from limited windows of detection and an inability to provide information about timing and dose patterns. Currently, no objective measure exists to detect opioid use in real time. We propose Opi-Track, a wearable sensor-based system to passively and objectively detect opioid use in real time. As a preliminary step, we conducted a field study to monitor opioid use in a hospital setting. A total of 36 inpatients were recruited to participate. Subjects received intravenous opiate analgesics at their physician's discretion and were asked to wear the Empatica E4 wristband throughout their entire hospital stay. The E4 is a medical-grade device which continuously captures accelerometry, skin temperature, electrodermal activity, and heart rate signals. Ground truth data for the occurrence and timing of opiate administrations was obtained via participant report and through the electronic medical record. A total of 2,070 hours of data from the E4 were obtained, which included 339 opioid administrations.
Before we try to model the physiological changes to detect opioid administration, we wanted to see if the wrist-on sensor is sensitive to register physiological changes associated with opioid administration and whether these changes are statistically significant. We performed a paired t-test analysis between physiological signals by applying different statistical functions and observed several of these are statistically significant. This experiment established a confidence that we could indeed detect administration events. Following is the Channel-Temporal attention TCN architecture used for jointly predicting opioid administration and opioid moment detection. Given physiological signal information of multiple modalities from a time window, our model detects if an opioid administration occurred in this time window or not. And if an administration is detected, it then predicts the exact moment of administration in this window. The design of this architecture has been motivated by previous statistical findings and medical observations. There are essentially four main components to this architecture. The first one is the Depthwise block. The input to the model is a time-windowed multimodal physiological signal. While performing paired t-test analysis, we observed different features from different modalities showed different trends during an administration. To capture these unique modality-specific trends, our model at first uses depthwise convolutions to extract features from each modality separately. Going forward, we use convolutions which capture cross-modality interactions. A relatively large time sequences as input is required for opioid use modeling due to the inherent time delay for the opioid to metabolize in the body. To consider such large input time sequences, we use TCN architecture. TCNs are a combination of RNNs and CNNs. The key characteristic of TCN are causal dilated convolutions. These convolutions allow the receptive field of the model to grow exponential of the network depth, allowing the model to capture larger time sequences. To weigh the contribution of different modalities, we use a channel attention block, and to aid the model in attending to only the important time points, we use a temporal-based self-attention block. Please refer to our paper for more information about these blocks. Now coming to the results, for opioid administration detection, which is a binary classification, following is the combined confusion matrix from leave-on subject-out cross-validation. We got a mean weighted F1 score of 0.8. For opioid moment prediction, following is the scatter plot between actual administration time and predicted administration. We got mean normalized absolute error of 8.6. We next broke down the performance of our model across different demographic groups. We observed that while the model in general performed well in both male and females, it is slightly better in males. We consider this result with caution, as the reason might be females having more opioid administration while having a smaller dataset size in our case. Across different BMI categories, the model performed uniformly. Previous studies had shown to indicate relatively similar pharmacokinetics irrespective of the BMI ranges. Repeated opioid exposure can lead to opioid tolerance, requiring as a result higher amount of dosage to reach a certain effect. We observed that it is easier to detect in participants who previously had no exposure to opioid as compared to participants who are chronic users. Next, we did an ablation-based study to observe the importance of different physiological signals. To find the importance of a modality, we removed it from all the inputs and retrained the model with the remaining modalities. Our hypothesis is that decrease in performance reflects the modality's importance. We observed that heart rate and interbeat interval signal contributed the most for opioid administration detection, and heart rate, EDA, and accelerometer signals contributed the most for opioid moment prediction. Skin temperature was found to be the least important for both these cases. We believe that this is due to the inconsistent nature of opioids to cause variable degree of increase and decrease in temperature after the administration. Well, the previous slide had shown to show the importance of different modalities across the total data set. Next, we wanted to investigate how our model placed importance on different modalities and time instances for individual predictions. For this, we apply a backpropagation based attribution method called gradient.input, in which we compute the importance of input features by taking the partial derivative of the output with respect to the input and multiplying this by the input itself. Consider the following example. The first subplot shows the input signal. The second subplot shows the output of gradient.input method. This gives an overview of the importance of different modalities at different time points. The third subplot shows the importance of different time points. In this case, EDA, interbeat interval, and heart rate signals contributed the most. Please refer to our paper for more examples and detailed explanations. Going forward, we are actively exploring two directions. First, can we detect opioid administrations taken orally? And if so, what are the physiological differences between intravenous and oral administrations? Next, can we identify the longitudinal effects of opioids on the physiological signals in a large population? And that concludes our work. Thank you very much.